Hello and welcome. My name is Liana Abascal, and I'm really excited to be participating in this virtual conference and talking to you all today. I am a clinical health psychologist in San Diego, and I have a private practice where I work with people with diabetes, primarily type 1, but also type 2. And I also have expertise in working with eating disorders and the conjunction of the two. Um, Something else I do, I'm on faculty at Alliant University here in town, and I teach health psychology in their PsyD doctorate program. So let's talk today about diabulimia and other eating issues. And we kind of have a tall order of what we want to cover for today. The description for this talk was managing weight and diabetes can be tricky, especially with all the intense focus on food, labels, numbers, and control. How do you regain a sense of balance when you've restricted yourself for too long? So this is a tall order. We're going to do our best to cover all these topics. And let's talk about diabetes a little bit at first. So living with diabetes is also a bit of a tall order. It's a big job that you never wanted, right? You never applied for. The daily self-care, if you were to actually count up all the recommendations that have been made to you over time, can be upwards of 150 tasks that you're supposed to be doing every day. Probably a little, it's a full-time job, right? Constant decision making when it comes to managing what you're eating, where your numbers are, what do you need to do to treat. There's no vacations from this, right? 24/7, you are doing a lot of work in order to, in a sense, be someone who has a working pancreas, right? And it feels like all these targets are constantly moving, right? You're constantly chasing numbers and it feels like it's never good enough and there's no finish line. And most other people really don't know how much work is involved. So it can feel a little lonely and isolating in that way. And then we have our friend, the blood glucose fairy. Let's not forget about her. So we might describe her as invisible, mischievous pixie who, whenever she feels like it, taps you with her magic wand, causing your blood glucose to go really wacky, right? So what are we saying here? Basically, diabetes can be unpredictable. You can do the same thing every single day and get different results, right? It's some of these issues that lead to diabetes distress and diabetes burnout. I like being able to conceptualize this unpredictability as a fairy. You can say, oh, fairy visited just now. Doesn't she look kind of diabolical with her horns and her not quite a wand, it almost looks like a syringe there. Okay, so within diabetes, we also have this fallacy of having perfect control or perfect management, right? It's this, we're kind of always chasing the carrot, always trying to get as close numbers in range, all these things that we are aiming for. And there really is no perfect. We're going to talk more about this and how to get comfortable with what might be a good enough. So diabetes in and of itself, it's a lot of work. We know that. What's so complicated about eating in diabetes? Well, let's talk about that a little bit. Eating itself is incredibly complicated, right? There is so much information and misinformation that is out there. And when I say out there, I mean, on the World Wide Web, you can find anything to support any dietary idea that you have. Some of it may not be legitimate peer-reviewed research, and some of it is. There's a lot of information that needs to be digested, right, in order to understand, well, what truly is good for me, just as a person, even without diabetes, right? And then throwing type 1 into the mix, There's a lot of information out there on what one should do if you have type 1 diabetes. And some of it conflicts with itself as well, right? So there's a bit of that double whammy of what do I eat? What's okay to eat? And we have language like, hey, watch your carbs, right? Well, carbs, are we talking about the hard candy or are we talking about broccoli? You know, within the dietary world, there's this habit of kind of lumping things according to macronutrients that isn't really helpful when it comes to overall health and nutrition, right? And we know even these items don't affect your blood glucose in the same way. So it's hard to navigate all of this and determine how should I be eating? Within diabetes, you have to focus on the carbs, right? You can't get away from that. So even if you are, you know what, I'm becoming a little obsessive, I don't want to focus on calories, on counting anything, you usually have no choice but to focus on that with the carbs, right? Diabetes management, it breeds perfectionism. The messages that we get from medical staff, from the media, from other people who don't quite understand diabetes have an idea that you can, it's a perfect equation of I'm going to do X, Y, and I always get Z. And if I don't, then I've done something wrong and I need to try harder, right? So these ideas get continued, and it becomes really easy to beat up on yourself. There are things about eating and diabetes that are unique too, right? So if you find yourself stuffing your face because you're really super low, was that binge eating, or was that I was low, I felt like I was going to die, of course I'm going to get food in, right? How do we define that? How do we know what is helpful and what isn't helpful? Not taking all your insulin works for losing weight if that's what your goal is. There's some consequences to that. We're going to talk about that some more, right? But it is effective for losing weight. When we think about eating in general, and talking to dietitians, maybe even to CDEs, there's this idea of intuitive eating, of listening to the body about what the body wants, and are you hungry, are you full, where are you, somewhere in between. And this is a little bit of, I call it the Shangri-La. I think it's a great long-term goal to move towards. However, we know that people with diabetes have hunger and satiety signals that are disrupted. The hormones are disrupted. I've done a binge eating class for people with type 1, and it was amazing to me. I had one participant who said, I never feel hungry. And I never had that sensation of feeling hungry, yet she struggled with binge eating. Another participant said, I never feel full. It does not matter what I eat. I am always feeling ravenous. So people can have different disruptions as well with type 1, but it makes this idea of intuitive eating that much harder. Excuse me. All right, so let's go over some typical ways that people might struggle with eating and with type 1. So let's meet Alex here. She's 26 years old. She's been type 1 for 14 years. Her A1C is almost 11 right now. It's been worse. It's also been better sometimes. She's noticed that her vision has been blurry sometimes, especially when she's particularly high. Needs to get her eyes checked. She's kind of been pushing that off. She has a 9-year history of disordered eating and binge eats about 2 times a week, usually undertreats with insulin. So she takes some insulin, but not as much as what would be indicated, and has a pretty chaotic eating schedule. She rarely eats meals. She's either grazing, trying to not eat, or finds herself binge eating. Doesn't really test her blood glucose. She says, why bother? I know it's usually high. It's not really giving me information I don't know. She's had multiple DKA episodes in the past, tries to avoid going to her endo and other physician visits, right? She's content currently at her weight, but the possibility of gaining weight is terrifying. So the idea of maybe taking as much insulin as is indicated and getting her A1C down, she's equating with that's going to lead to weight gain, and I can't live with that. All right, let's meet Debbie. So she's 19 years old. She's been type 1 for 2 years, and her A1C is 7.1. She has occasionally engaged in binging and purging since puberty, so predating her diagnosis with type 1. And now she engages in that behavior almost daily that she is away at college in her first year. She doesn't really want others to know she has type 1. So when she's in the dorms or in class, when she's out around others, she tries to run a little bit high so that she doesn't have to worry about her diabetes care in front of others. All right, let's talk about Sarah. So Sarah's 43 years old. She was diagnosed at age 36 with type 1. Her last known A1C, which she hasn't had done in a while, is 13.2. And for most of her life before she was diagnosed with type 1, she was in a BMI category that is labeled as obese. So she started losing a lot of weight inexplicably, which led to her diagnosis with type 1. And she feels like she is normal for the first time in her life. She gets lots of compliments about her weight loss. She realizes how much weight bias she had faced previous to this time, because now that she feels that she's in an average size body, she isn't observing that as much. And if management equals weight gain, in her mind, she's equating these, then she wants nothing of it. She hops on the scale multiple times daily, and basically the number that she is at dictates if she will bolus for any of her meals. All right, let's meet Alex, 26 years old, type 1 for 14 years. A1C is a 10.9. He's starting to have some complications. He has a 9-year history of disordered eating and was hospitalized last month for DKA. Does that sound familiar at all? So Alex was also the first person we met. So see what I did there? We want to make sure that we are including men when we are talking about disordered eating and eating disorders, and especially in the type 1 world. One of the things that we talk about in eating disorders is that you can't put a face on an eating disorder. Eating disorders happen in any gender identity. They happen at any size, and it's important to acknowledge that. So let's talk about the continuum of eating disorder symptoms. So on the left here, we have healthy weight, healthy eating exercise, good body image, followed by weight, shape, preoccupation, maybe some yo-yo dieting, excessive exercising, fasting, compulsive overeating, maybe some steroid use or muscle dysmorphia that we tend to see in males more frequently. Certainly distorted body image, starting to abuse laxatives, binging and purging. And all the way on the right, we have anorexia, bulimia, binge eating disorder. So there's a really wide range of where somebody might find themselves in this continuum. I have overlaid here how we might think of type 1 specific symptoms. So, a high rigidity of eating choices, right? Occasional emitting of insulin needs to be added in here. And then what we call diabulimia that we'll talk about more in a moment. So let's cover some definitions so that we're all on the same page of what we're talking about. So specifically when it comes to the overlap of eating disorders and diabetes, within the literature, it is often called, or in the research literature, so ED-DM type 1, T1, right? So this is type 1 diabetes and eating disorders, and it actually is a pretty large category. So this can include what we might call traditional eating disorders in the sense that they occur in people without diabetes as well. So anorexia nervosa, binge eating disorder. There's what is called OSFED, other specified feeding and eating disorders, which is kind of a catch-all category. It's usually people who are subclinical. So maybe they have some symptoms of an eating disorder, but not enough to meet criteria. Still of clinical note. And then we have what we might call traditional bulimia nervosa. So somebody who binge eats and uses methods of purging like excessive exercise or vomiting or laxatives. And then there's also diabulimia, which is bulimia nervosa specific to those with type 1. And the purging occurs by omitting insulin. Okay. And diabulimia, so sometimes you will see that name in the literature, sometimes you won't. I have found working with clients, with patients, that they actually really embrace having a name that is specific to what they are going through, and that it was very comforting to know that they weren't alone, that there was a name for this condition. And so what diabulimia is deliberately misusing your insulin. And this could be on many different levels. So not taking any at all. It could be taking less insulin than what's indicated. It could be maybe taking your full dose that would be indicated, but it's delayed. It could be altering the insulin itself to render it inactive. So that's something that we see in people who perhaps are being monitored for their insulin usage. Then they sort of use tricks to make it appear as if they are dosing when they perhaps are not. And so what happens if you don't take your insulin, right? You can't metabolize the glucose. It leads to purging of the glucose and those calories. Technically, not taking your insulin falls under misuse of medications, which is one of the criteria for compensatory behaviors in bulimia nervosa. So those with diabulimia can be diagnosed with bulimia nervosa. And part of why that's important is because of how insurance works and diagnoses that are covered by insurance and are covered by law. In California, we have a parity law where certain diagnoses need to be covered by insurance. Bulimia nervosa is one of them. So that becomes really important if you are in a situation where you're omitting insulin and looking for help. It's good to know that you can fall under the bulimia nervosa umbrella. Okay, so why do people omit insulin? You know, for some people this might be obvious, for others not so much. You can imagine if you're not taking your insulin, if you're not having to do those mental gymnastics, right? It is less effort, right? You're not having to figure out, what do I need a dose for? How much did I eat? And it can feel like liberation from those eating restraints, right? I can kind of eat whatever I want because I'm going to ignore it. I don't care how many carbs were in there. I'm not going to dose, right? So it almost brings a level of denial around the diabetes. And, you know, people will sometimes talk about like it felt like a vacation to not have to think about it, not have to deal with it. As you can imagine, if you are taking less insulin, you're running high, right? So you have fewer hypoglycemic episodes, right? And those can be incredibly scary for people. Running high also has sedative effects, and some people enjoy that. It helps them to sleep. It can feel like a little bit like a drugging type of effect. And not last but not least, it is actually efficient purging of excessive calories, right? It works, and I'm uncomfortable saying that because yes, it does work to purge the extra calories, and there's really horrible consequences to it. Okay, so what do we see when it comes to prevalence? How common is this? So when we look at just eating disorders in the population, anorexia nervosa is about 1% of the population. Bulimia is about 1.5 to 2% of the population. Subclinical eating disorders, there's a big range depending on how research was done to assess for numbers, ranges from about 1 to 10%. When it comes to type 1 diabetes, the risk is reported as high as 2.4 times. So meaning someone with type 1 diabetes is 2.4 times more likely to develop an eating disorder than the general population. Okay. And what we see is that for clinical disorders, for people with type 1, the prevalence is about 10% of the population. Subclinical is as high as 14%, and disordered eating, so when we think about this continuum again, is as high as 37%. When looking at insulin omission specifically, 10 to 15% of adolescents and as high as 40% in adults have reported omitting insulin. So why are these numbers so high, right? It's a little scary, a little daunting to see that there's such increased risk of those with type 1 diabetes. And some of this really makes sense. Diabetes and eating disorders, it creates a perfect storm. So a lot of the risk factors that go into developing an eating disorder are kind of emphasized in diabetes. So this perfectionism when it comes around, what you're eating and how you're eating, and I should be doing this, it completely mirrors the eating disorder mindset, right? So there's no way to get away from some of that meal planning, portion size, attention to carbs, right? We're talking about exercise and weight a lot. The same language is used, right? This idea of like, oh, there's good foods and bad foods, and I'm cheating, and I should be eating this, and I shouldn't be eating that. Both those kind of language patterns occur within diabetes and eating disorders. The comorbidities, so the other mental health struggles that can occur in diabetes and in eating disorders happen in both. Like there's a greater prevalence of depression. There's promotion of unreasonable self-expectations, right? Within the eating disorder world, expectations about what you should be eating, how you might look, what you might weigh. Within the diabetes world, what your A1C needs to be, this idea of being perfect about what you're eating and how you're dosing, right? And then we know that sometimes appropriate diabetes self-care can lead to weight gain, right? Many people have the experience of losing weight, ending up in the hospital, in DKA, right? Receiving the diagnosis, put on insulin, and it leads to gaining weight. And so this is that association that occurs. And again, insulin omission, it does help to get weight down, and people learn this at diagnosis. Okay. So let's talk a little bit about the consequences. I'm not going to kind of hammer this in too much. We know scare tactics don't work. And people mostly know the consequences, right? The consequences that occur with eating disorders and diabetes are the typical consequences, the typical complications we might see over time in someone with diabetes that is not well managed, right? So elevated A1C, DKA, retinopathy, neuropathy, issues with blood lipids, and there's elevated mortality risks. We'll talk about that in a moment too. But what happens when you combine insulin omission with diabetes? It's no longer an if on whether you will get complications. Not taking your insulin greatly accelerates and intensifies complications. That's why I have this pedal to the metal graphic here. I have seen in 20-year-olds complications that are usually seen after a lifetime of struggling with management of type 1. So I've had people in their 20s who are on dialysis and on the list for kidney transplant, for example, people with night blindness or legal blindness. So all those complications become greatly accelerated and intensified. Okay, so I want to just touch on the mortality statistics of what we see for insulin omission. So this is a really interesting study that was done on women with type 1 diabetes, and it was followed up 11 years later. Okay, so these are 234 women with type 1. Their average age was 45 years old. They on average had 28 years of type 1, and they were given an assessment initially at baseline where one of the questions was, I take less insulin than I should, and they could answer either yes or no. So of those women, 71 said yes to that question, I take less insulin than I should. Those women over the course of 11 years had threefold the risk of mortality. Okay. So 3 times the risk of dying. And the mean age of death was significantly younger than it was for those who said no to that question. So of the women who said yes and passed away, they were on average age 45, whereas those women who said no and passed away were on average 58 years. So incredible risk of mortality and early mortality with insulin omission. Okay, so now what? We've talked about some of these consequences, the prevalence, some of these behaviors, how you might be along this continuum and not at either extreme. So what do we do with this now? How do we work on dealing with some of these issues, right? So we're learning to be a diabetes rock star, right? This is the theme of the conference. So let's talk about that. And to follow our rock star theme, I'm saying give peace a chance. And you might be saying, what? Like make peace with diabetes? You must be crazy. You can make peace with diabetes, and you can make peace with food too. Let's talk about some ways to do this. So this is the analogy that I really like to use actually for everyone with type 1. I talk about it with adolescents, with parents, with adults. So we know what a sidecar is, right? Sidecar is this little doohickey we put on the side of the motorcycle. So I like to conceptualize this as this is the sidecar of life, okay? You are driving the motorcycle. Diabetes is in the sidecar. It is along for the ride. You're not going to be able to ditch it, right? It's not going anywhere. It is going to be there with you. However, diabetes is not driving the motorcycle. You are. And diabetes is the sidekick, but you are in control. you are getting to make the decisions and drive through life. Okay. So thinking about it that way, as diabetes is along for the ride, I can't ignore it. I can't ditch it. It's going to be there, yet I'm in control. I'm the one who's driving. I included the little graphic of the giraffes because who doesn't love giraffes? Isn't that the cutest thing? All right, let's move on. Okay, so how do we get away from this perfectionistic thinking? It takes some cognitive work, right? It's allowing yourself to move into that gray area that can feel really uncomfortable for people. And increasing your own mindfulness to observe your own black and white thinking is really important, right? Being aware of how our thoughts go to, I'm either doing this right or I'm not doing this right. There's a huge area in between, right? And this shift from on or off and thinking of self-care is incredibly important too. Okay, let's move on to the next one here. So what's your diabetes philosophy, right? What are the big goals that you are aiming for? You want to have good enough blood glucose, right? We'll talk more about what good enough is. Probably don't want to have a lot of uncomfortable lows. Nobody wants to have that, right? And not be running intentionally high either. And you want to have a life. Is it possible? Yes. Is it difficult? Yes. Okay. But it can be done. And so thinking about what your own philosophy is incredibly important. Working with your endo in deciding what is good enough is incredibly important. Letting go of some of this perfectionistic thinking that sometimes gets really reinforced by the diabetes community. And you need to continue to reinforce for yourself, hey, I'm living in the gray area. I'm not being black and white about this. Being black and white has not worked for me in the past. Okay, so what do we know? So A1C, it does matter, right? So I'm not saying like throw it all out, you just focus on being good enough. Don't pay any attention to what your A1C is. Of course, we have to know what our numbers are. Of course, we need to know where our A1C is. And some of the major large trials that we have of type 1, so they have shown us that A1C does matter, right? And when we look a little closer, it's important to be aware. So the averages of people in these trials, in the diabetes control and complication trial known as DCCT and the EDICT study, those averages were a 7 and an 8 of A1C. And these were of the people who had improvements and reduced their risk of complications, right? So of course, we know the guidelines are under 7, right? Yet we know there's a lot of good that comes from getting your A1C down from anywhere that you might be starting at. So 1 point reduction in A1C reduces the risk of 30%. So work with your doctor to focus on what's a realistic number for you, short-term, long-term, and know that any little change that you make is moving you in a direction that is more healthful. Okay. Help is a good thing. Asking for help is a good thing. It's okay to ask for help, right? I might be biased. I'm a psychologist. However, we are here to help. And for people who are dealing with diabetes and eating issues, they can feel very stuck between two worlds, right? There might be places where people understand diabetes and other places where people only understand eating disorders, and it's hard to get that targeted care. There's also few treatment studies. A lot of what we know about in our approach about how to treat eating disorders within the diabetes population comes from what we know about eating disorders in general. So we take the insights from there, and it helps with some answers, but not all. So let's just talk a little bit. So general treatment for eating disorder. So weight stabilization, medical stabilization, if needed, is a number one priority. Talk therapy, both individual and group, is primary treatment for eating disorders. And there are different types of therapies that have been found to have evidence for treating eating disorders. So cognitive behavioral therapy for eating disorders, CBTE, dialectical behavior therapy, also known as DBT, acceptance and commitment therapy, known as ACT, and family-based therapy, FBT, which is also sometimes called the Maudsley approach. And that latter one, the family-based therapy, is often done with patients who are younger, so adolescents or early adults, and it's done primarily for anorexia nervosa. So that one's a little bit more specialized. And then antidepressants and other medications are often used in eating disorders, and also to treat comorbidities that might be occurring, like depression. Okay, so general eating disorder treatment goals. Patient takes an active role in treatment. You have a multidisciplinary team, so that includes your therapist, it includes probably a psychiatrist, a dietitian, right? And the goals are to establish regular, flexible eating patterns, eliminate dieting and food restriction, develop healthier means of coping with negative emotions, right? And decreasing that perfectionism and black and white thinking that can keep us very stuck. All right, so let's talk a little bit about treatment strategies for specifically eating disorders and diabetes. So there is much more collaboration with the patient, specifically because we need to meet them where they are. We're going to talk about that a little bit. There are going to be specific targets for insulin use, right? Your multidisciplinary team is going to include your endocrinologist. That is a really important piece. And finding an endo who really understands the eating disorder side of things is key as well. Okay, when we're talking about insulin omission, specific strategies, safety first, right? So staying out of the hospital, staying out of the ICU. And I find that this is actually something very motivating for patients. They don't want to be missing work or time from their families or an entire semester of college if they end up hospitalized, right? So it's something that can be really motivating. So agreement to take basal insulin or some portion thereof can be a safety strategy. Okay, small steps, right? So moving towards normal glycemic goals too quickly are not appropriate. There is evidence in the research that it can lead to worsening retinopathy, and it can make neuropathy pain worse. And it also scares the heck out of the patients, which we'll talk about. So small, incremental, and attainable goals are what we're focusing on. So gradually increasing the amount of insulin dosing, the regularity of it, and of blood glucose monitoring if that has been an issue as well. Often these days people have CGMs that makes monitoring a little easier, but they will often not wear them. So agreeing to wear the CGM might be a goal. Gradually increasing food intake if that is needed, flexibility of a meal plan, regularity of eating routine, and focusing on safer coping skills. And so important, I really take a focus of meeting people where they are. And so asking a lot of questions, and not making assumptions like, do you bolus? If you do, how often? How many units do you give yourself? Are there certain meals that you always bolus after, or other ones that you never bolus after? And when someone is just getting started, we're not worried about ratios, right? Ratios can come later. But if they aren't taking any insulin other than basal insulin, then I always say taking 1 unit is better than 0. And so we start very small. And if you notice on the previous slide, I said, not only increasing the insulin, but increasing the regularity of taking insulin. So as opposed to I'd rather have someone almost take 1 unit after each meal than doing 3 units at breakfast and not doing any for the other. So in other words, it just starts that pattern of I'm always going to treat something when I eat. And that starts to get that habit ingrained again. There's barriers. There's barriers that come up, difficulties that come up for patients in this process. Okay. Insulin edema is no joke. Insulin edema occurs and it can be intense in some patients. So this is if you are not taking a lot of insulin and you're increasing your insulin, it leads to excessive retaining of water. I had one patient who used to say that she looked like the elephant man when she had insulin edema. So you can imagine her struggle in trying to increase her insulin. She would increase her insulin, felt like she looked like the elephant man, and would say, well, forget that. I'm not going to do that anymore. So we had the tiniest little baby steps that we had to take and increase her insulin. And then we would increase a little bit and do that for a few days. So she could kind of stabilize and get used to. And if she had any insulin edema, it went down. Then we'd add a little bit more and stabilize her there. So small, incremental. Okay, so hyperglycemia, right? There's such a thing as glucose toxicity. So initially, if you've been running really high, larger amounts of insulin are required to get you down, and then you need to make frequent adjustments. And that can be a really scary process, right? It feels like you're giving yourself like a ton of insulin. However, you're just not responding in a way that you used to, yet your body will start to respond. And so that adjustment needs to happen, hopefully without going super low. And if you've been running really high, well, then taking a little bit less starts to feel like you're going low, even if you aren't going low, right? So this can be problematic. I have this quote in here, I'm not high. So this is part of that language that, we become so accustomed to in the type 1 world, where I think it's funny. Someone will say to me, oh yeah, I'm high right now. And somebody else will hear it and say, you're high? And it's just, no, I'm not high. I'm high. My blood glucose numbers are high. This meter that we see here, I had another client that every time her meter told her she was high, she would say hi back to it. She'd go, hi, good to see you. Hi, thanks for that. Okay, so on the other side, we have hypoglycemia, fear of hypoglycemia, right? So hypoglycemia can trigger a binge, right? It can lead to binge eating. And again, is this maybe initially you feel like you're going to die, so you're eating so you don't feel like you're going to die? And yet that idea of, okay, I blew it, so now I'm just going to eat whatever the heck I want, right? So it can then further trigger binge eating. Hypoglycemia is scary. You need to intervene, and sometimes other people have to intervene for you if you lose consciousness. And it can feel like you're going low even when you're not, right? If you've been running really high, running a little bit lower starts to feel uncomfortable. These are all barriers that come up in this process. Okay, getting help. So, goodness, what to say about this? I have had a lot of patients come and see me. They're not sure about getting help and they are having a hard time being motivated. It feels like there's no downside to what they're doing. In my experience, it's the reality of complications that usually lead people to stick to treatment. it's that fear once they see that they're starting to have complications. I wish I had the magic formula to be able to help people before they get to that point. But in my experience, I've only had one patient who omitted insulin and stayed through treatment who did not already do that due to complications. So that is the reality, that just when people are presenting for help and where they might be is very much depends on what their success might be like. Okay, so let's talk a little bit. This is our last section, building compassion and self-compassion. So this is tips for you as the person who might be struggling with some of these, as well as the loved ones of people with type 1. So I really want to normalize dissonance and ambivalence. Ambivalence occurs in diabetes and it occurs in eating disorders, right? And ambivalence, quite literally means that you simultaneously have opposing viewpoints of something, right? Or opposing desires. So somebody may want recovery and they want to stay in their disorder. The thought of not doing so is too scary. And so that can feel really confusing to the patient, and it can be really confusing to the person around them, right? Because one moment they may seem very recovery minded, and in another, it feels like they are retreating. That is a normal part of the process. And working through that ambivalence is, I feel like, the vast majority of the work. Once you can strengthen that recovery voice, that helps immensely. Okay, normalizing the pull of dishonesty and taking a non-judgmental stance. Both diabetes and eating disorders lend to lying about things, right? Did you eat that? Did you take your insulin? Oh, yeah, sure. No, I didn't eat that. Yeah, I took my insulin, right? Nobody wants to be in trouble or get yelled at, right? And so for the person going through it, they may identify, well, I'm not a liar, right? It feels uncomfortable. All of a sudden, I'm like lying left and right. And for family members and people around them, it feels very personal. I can't believe this person just lied to me, right? So it's really important to understand that that is part of the disorder and it isn't a fundamental change in the person, okay? Taking a non-judgmental stance is really important, and it's hard. It's hard to practice a poker face. If you realize somebody might be lying about something, okay, you need to give them the benefit of the doubt. And I always like to tell my patients and family members and loved ones that I love confessions. So I tell people, I know you're going to lie to me. That's part of it. That's part of the disorder. And later you might be like, darn it, I really shouldn't have said that. I'm going to tell her that I lied. And people confess. And I say, yay, thanks for letting me know. I really appreciate that. Let's talk about what can we do with this now? And so providing a safe space to allow people to talk about that can go a very long way. As part of this is kind of what I call trickiness. So there's a lot of deception that goes on. Sometimes people only test when they know their numbers are good, right? Because they can feel that they're not too high, they're not too low. And then you look at their meter and you're like, oh, this is beautiful. How come this isn't matching up with my A1C? What's going on, right? They might test with control serum. They might give a fake shot. They might put saline in insulin, right? There's a lot of things that go on. And again, remember, this is not an attempt to be malicious. It's driven by the disorder trying to protect itself and the person not wanting to be in trouble, right? And the person themselves might be really uncomfortable with knowing they're engaging in these behaviors. And that doesn't sit right with them either, right? So we need to put it out there and know that these things happen and talk about it and allow people to talk about it. So this is a book I recommend to patients and to family members alike because it really helps with this understanding that the person is not their disorder. This was written by someone who was in recovery from an eating disorder, not someone with type 1. However, it really describes the eating disorder mindset. And a breakthrough for her in her own treatment was to kind of personify the eating disorder as this person, Ed. And she would literally talk to Ed in a chair as part of her therapy. And she was able to get some distance from the disorder. Instead of thinking these things were a part of her, she was able to see it as separate from herself. And then those around her were able to see it as the disorder and separate from her as a person. So, highly recommend that. Okay. A note on validation. We all love validation. Do it as much as possible for the people around you. Validation is the recognition and acceptance of another person's thoughts, feelings, sensations, and behaviors as understandable, right? It doesn't mean that you're agreeing with them. Okay, so that's a distinction that people struggle with, because they say, I can't agree with them. You know, I can see my loved one is basically emaciated. They look in the mirror and they see themselves as overweight. I can't agree that that's what they look like. They don't look like that. Yet this is the reality of what that person is seeing and feeling. So you can acknowledge what they're seeing and feeling. You know, I'm sorry you're feeling that way. God, that must suck to look in the mirror and see that. That's not what I see. I'm sorry that that's distorted for you, right? So you're validating their experience. And that goes a really long way in being able to open up and talk about these issues, okay? All right, be gentle on yourself, be gentle on others, give yourself a hug. Thank you so much for your time. Any questions, comments, anything, please email me. I would love to hear from you. Again, thank you for your time and take care.